So I've been asked to talk about treatment sequencing and treatment breaks, so I'm going to move on quickly. And really just to remind people that about 45% of melanomas have a BRAF mutation, and many of you in this room, if you've got stage 3 or 4 melanoma, will know your BRAF status, I hope. And it's really a key issue is choosing between immunotherapy and targeted therapy. Immunotherapy is relevant for all patients. BRAF targeted therapy clearly is relevant to those people who have a BRAF mutation. And I just want to start by showing you these survival curves. Cindy's done a fantastic job explaining Kaplan-Meier curves to you. But this is an important set of data taken from all the key registration trials, all the key international trials that have been performed over the last few years, comparing against conventional chemotherapy with immunotherapy and targeted therapy, and put all the data together in this single graph. And you can see that the bottom curve, the blue curve, represents chemotherapy, patients who've received chemotherapy. And then you can see gradually that those curves are shifting over to the right, suggesting an improvement in outcomes for patients. And if we take you through those, the next curve is the brown curve, which is the ipilimumab curve, showing an improvement. That was the first time we'd improved survival for our patients. The green curve is the BRAF inhibitor, vemurafenib, dabrafenib. Again, they were the next drugs that came in, some of you will know. And then the next 3 curves are combination therapy. So they're all doing well, but how do we choose between BRAF targeted therapy and immunotherapy in the BRAF mutant population specifically? And this is taxing a lot of people. And I want to, again, just focus on those curves. So the kind of reddy brown and the brown curves represent immunotherapy. The reddy brown is the anti-PD-1 antibody, and the brown one is the combination. And those are largely from the trial that Cindy's just shown us, the 067 trial. You can see that there's just a marginal difference, which is what she was describing. And the other curve, the dark green curve that the arrow is pointing to, is the BRAF-MEK combination, dabrafenib and trametinib. And you can see that at the top stage, in the early stage, if you look down the bottom, this is time measured in months. In the first year or so, the curve that is highest up, the patients who are doing best, are those patients who've received BRAF-MEK inhibitor combination. But later on, if you follow those curves, there's a crossing, and the green curve now falls below the brown and the kind of reddy brown curves, the immunotherapy curves, suggesting that in the longer term, those patients who received immunotherapy have done better. So that's quite taxing. How do we use that information in deciding and talking to patients about which treatment to use? And it's not an accurate science. You've heard a lot this morning about clinical decision-making and grey areas. And it's the same at the moment in the clinic. We talked about biomarkers. We'd love to have clear biomarkers, but we're not there yet. But the people who I think at the moment we would offer a BRAF-targeted therapy to first, I've identified here. So you really want, if you want a high response rate, these are the people who've got high disease burden, they've got a rapidly growing cancer and they're coming in quite sick, or they've got secondaries in the head, which is a very difficult area to manage. Those patients who are getting symptomatic and unwell of their treatment, you want a very quick response. And BRAF is actually almost a perfect biomarker because you know that if you give them the BRAF targeted therapy, they will respond early. And so those people are the ones who we're probably going to go straight on to the BRAF targeted drugs. On the other hand, we are picking up disease a lot earlier, and we're getting a lot of people coming through with what we would describe as lower volume disease. So small changes on scans in people who may not have any symptoms. We're seeing quite a lot of young people as well as older people. And in those people, the primary goal may be survival. and I think many people in this room will grapple with these issues about quality and quantity of life. But if survival is your goal, based upon those curves that we've just been describing, then maybe immunotherapy is the right way forward. You don't get such a high response rate, but if you respond, your chances of survival are much higher. So those are the kind of issues that we talk about, and at the bottom there is about patient choice. And so it's about us trying to explain to the patient when they come into our clinic room about their options and help them to understand and to help them to make choices and be part of the decision making. So there are no hard and fast rules. There is, again, this issue, we've talked earlier, Cindy beautifully described this issue of should we be going with monotherapy or combination immunotherapy. The curves there are relatively close together, and we again need to make choices, and this is across all patients, both the BRAF mutant and the BRAF wild type patients. Should we be going for combos or monotherapy? Well, we've seen very clearly that PD-1 antibodies are superior to anti-CTLA-4 antibodies, and therefore we do use nivolumab, pembrolizumab as our first choice monotherapy as opposed to ipilimumab, so we can sequence those, or we can go in with the combination. And we've seen this data. This is the 067 trial data. I'm not going to go through that again, but we've seen that survival data beautifully explained by Cindy. And the issue is, if you look back here at that small marginal gain that we've been discussing with the combination, is the cost of the toxicity risk worth it? And we haven't mentioned much about toxicity, but these drugs do generate some quite complex immune-related side effects. Some of you may even have experienced these for yourself. Monotherapy, nivolumab and pembrolizumab, are actually very well tolerated. So the risk of serious side effects, about 1 in 10, where people may get hospitalized for their side effects. But if you combine those drugs up front together, the toxicity is enormously higher. So about over 50% of people will get severe or life-threatening side effects during that usually in that first 12 weeks of treatment. And about 1 in 2 of those people, so 50% chance of being hospitalized for quite serious toxicities. So again, you can see that all this needs to be discussed with patients as to whether you're prepared to take those risks. If you're 85 versus 35, you may view those kind of risks differently, and therefore it does have to be that joint decision between us and yourself. And just to demonstrate a couple of examples of patients, I'm not going to go into the details of this particular case, but this is a 39-year-old lady who came, again, she was young, she had low volume lung metastases, and she elected to have a combination ipi-nivo therapy. This is her time course. She started treatment in June, and during her first few treatments, within the first 2 treatments, she developed multiple toxicities. So she had a rash, she developed colitis, she was admitted, she remained in hospital for a number of weeks, being managed for quite severe colitis. She had to be tube fed. Then she developed on top of that hepatitis, her liver function went off, her thyroid function went off. We got her through all of that, and then she started to develop a really nasty, destructive polyarthritis. It's that the graph goes to 2007, but we're now 2017. We're now 2018, and she is alive and well and free of her melanoma, but she's living with her polyarthropathy. So again, those are difficult things, and she's a young woman with young children. And so these are real issues that we have to grapple with. On the other hand, this is another lady who came to us acutely admitted as an emergency with headaches and vomiting, very symptomatic, and a scan showed that she'd got multiple brain secondaries. We gave her some steroids which improved her condition to begin with, and we commenced her directly onto dabrafenib trametinib because we knew she had a BRAF mutation, and she did really well. She was able to get out of hospital, she gained some quality of life, although ultimately, as we see with these drugs, her cancer progressed and she did die of her disease. But we bought her some time to get her life in order and help her to just have a bit of quality of time. And that's a huge improvement, because previously people with brain metastases had a really difficult time in hospital with a very poor outcome, and very few were able to return home. So is sequencing evidence-based? Not really. It's more based upon clinical experience, but there are some formal trials. As Cindy said, we need to generate the evidence base, and there are some prospective trials that are setting up that will be involving future patients, and we will hopefully be able to use that information in the future. So I'm going to go on to treatment breaks. We've heard a little bit about that very politically complex and fiery area. There are different issues around the BRAF targeted agents and the checkpoint inhibitors. I'm going to try and stay as politically neutral as possible. So BRAF targeted therapies, 3 things to think about. Is this a strategy to delay secondary resistance? So the reason why that BRAF, those curves that you've seen with BRAF inhibitors don't seem to be flattening off quite the same way as we've seen in immunotherapy is the evolution of secondary resistance. So when people are on treatment, ultimately the cells learn to grow despite the treatment. And we call this secondary resistance. Is it an option for patients who've achieved to stop treatment if they've achieved a complete response? And can you retreat people? So first of all, treatment breaks to delay onset of secondary resistance. Well, this is some work that was done in mice. And the curve on the right basically shows a group of mice who were either continually treated with the first BRAF inhibitor, vemurafenib, or they were given an interrupted treatment program. And the curves that are dotted show that the mice died on treatment, but the straight lines at the top are the mice that had intermittent therapy, which is quite remarkable. And so this is something that we do need to test in people, and we're running a trial called the interim trial. We're leading that from Cambridge, and we're randomizing patients to either have conventional continuous dabrafenib trametinib or intermittent dosing to see whether we can replicate the mice data. And that may also be a good way of managing toxicity. Is it safe to stop targeted therapy in incomplete response? These are kind of the overall data that you see with these combination regimens. Very high overall response rates, but the complete response rates, everything disappearing from any scans, are in the order of somewhere between 10 and 20%. So in that cohort, can we stop treatment? You've seen a little bit of this data already. Did we see it? I'm not sure. I don't think Paul did show you this data, actually. But this is some data that has been pulled from some of the targeted therapy trials, which showed that in 106 patients who achieved a complete response, 20 of them stopped in their complete response for a variety of reasons. And having stopped, 8 of them progressed off their treatment. So that was a 40% progression. And we've seen that ourselves. We've got a bunch of patients who have stopped for various reasons in our centre. 6 patients who stopped mainly for toxicity, and actually all of them were in complete response, but 4 of them have recurred off treatment. So our impression is it's not necessarily a good thing to do, but the jury is still out. And then finally, can patients stopping targeted therapy be successfully rechallenged? So if you think about those patients, if you sequence those patients, you give them targeted therapy first. Unfortunately, some of those people will progress. They then get immunotherapy as their second-line treatment. If they progress again, can you go back and give them targeted therapy again? And this is some data that Paul Lorigan, one of our colleagues, led on, and actually has shown that in a cohort of just over 100 patients who were rechallenged at a subsequent time point, they actually achieved a very impressive survival, so progression-free survival there of 5 months and a median overall survival of 9.8 months. Doesn't sound a lot, but that's quite impressive. That's compared with what we were seeing with single-agent targeted therapy in the very early days. So it does appear that you can do that. We can't necessarily officially do it, so it comes back to some of those discussions we were having this morning about what we can and can't do through the NHS rules. To summarise the treatment breaks for BRAF targeted therapy, is it a strategy to delay secondary resistance? Thank you. Potentially being tested in the interim trial. Is it an option to stop treatment if a patient's achieved a complete response? I don't think I would recommend it to any of my patients. Is it an option to revisit after progression? Yes, but actually it's not formally funded. So just bear that in mind. Checkpoint inhibitors. How long should patients be treated for? We've already touched on that, and I'm just going to pick up on where Paul left off, and what happens again if we stop treatment. So the whole issue about how long we should treat with immunotherapy is limited in terms of the evidence base. So as we've heard, ipilimumab is a 12-week treatment. The PD-1 inhibitors are licensed to progression, and most of that, I'm afraid, has been driven by the pharmaceutical companies. But we do now have some data to suggest that we can stop, and Paul showed you the Keynote 06 data earlier today. This was the trial which involved treating patients with pembrolizumab for only 2 years. Okay, that's different to what we're doing now. These drugs are licensed to progression. But in this trial, in those patients who stopped treatment at 2 years, you can see how most of those patients did very well, having stopped their treatment. And you saw that again. I'm not going to do that again. But what we are doing in the UK, again, is trying to develop some good evidence base. And so we're going to do a national trial where patients who are progression-free at 1 year will be invited to take part in the trial and be randomized either to stop treatment or continue to progression or to 2 years, whatever their clinician thinks is the right thing to do. So there's the design of that trial. And it's literally just opening at the moment. So hopefully that will be a good thing to be developing some important information. Really, that's my summary. So sequencing treatment options for BRAF mutant melanoma is not terribly well evidence-based. It's a clinical basis, and we need to generate the evidence. Likewise, the whole issue of treatment breaks. We've got some good studies in the UK that we're going to be doing, hopefully, to try and build up the knowledge base so that we would be able to have a better informed discussion with our patients in the future. So I'm going to stop there. Thank you.
Mic on. Thank you. You spoke really quickly. Okay, we have time for 5 minutes of questions. Thanks, Sandy.
Early on in the presentation, you shared curves of survival on various treatments. I know that a lot of clinical trials exclude certain patients. For example, previous treatments, brain metastases. Yes. Are you seeing any differences in real-world data versus the trials?
Yes. So bear in mind that to get into those trials, they do pick out the fitter of our patient population. And so actually those survival curves are much, much better than real world. And if you look across the real world populations, you will see that people do worse. However, the relative benefits are still there. So what we do often do is after the registration trials, we will try and do real-world assessments, particularly to get more, to get evidence base in the cohorts of patients that aren't eligible for that trial, because the companies will really focus usually on the people who are likely to do best. But we need to learn about everybody, and most of those trials are done in, for example, cutaneous melanoma. We want to learn about people who have melanomas from other sites and body sites and so on. People with brain metastases are frequently excluded from trials, and they represent a very important cohort of our patients we need to learn more about. So we try and widen it up. We also want to learn more about safety and side effects in a real-world population. In a trial, it's a very controlled environment, and it's very different to being managed within the general hospital environment. So yes, there are differences, but it's pretty... what we have learned, for example, with the targeted therapies is that we are still seeing high response rates in patients with poorer performance status, with brain metastases and so on. For immunotherapies, we're probably learning that those less fit people are probably more difficult to salvage. So if you're needing, for example, significant doses of steroids to manage your brain secondaries, or have other significant health problems, so your fitness is poor, you're unlikely to be able to benefit with immunotherapy. So yeah, we are learning quite a lot, and we do put that data together, and we do try and publish it, and we do use that information and bring that into the conversation with our patients.
Hi. It's a follow-on question to Mel, really, about, as a patient, what would attract me to go onto a trial? Because the more, and forgive me for the first presentation that was done before yours, from a patient point of view, it just never seems to be on the agenda. Because with a phase 3 randomized trial, the thought of me as a stage 4 patient ending up on a control arm with the standard treatment, then actually forget it. I'll not bother. I won't go through the constraint of a trial. So do you think we need to change the structure, the way that phase 3 trials are done?
So there are lots of trials that don't recruit, and a lot of those trials may have very good questions, but unless they're attractive and acceptable to patients, they don't recruit. So it's really, really important as part of trial design that we involve patients, and more when we put together a trial management group, we have patient representation to help us to make the right decisions and to bring the patient voice through. On the other hand, all those trials represent real patients who have made the difference. So the people in this room who have received these kind of drugs are here because of thanks to those people who have taken part. So there is a degree of altruism. But I think one of the things is, the way that treatments evolve is that you're always starting from the basis of, at the very least, going into a randomized trial, you're getting what is ever the standard of care of the day. So we'll never go backwards. We'll take whatever is the standard of care at that time. So, for example, the first trials of these new therapies, dacarbazine was our conventional treatment. Patients didn't get nothing. There was an option of getting that treatment or getting a new treatment. And quite often we have what's called a crossover design, so that if you are shown not to benefit, then at that point there may be the option to cross over and get the alternative treatment. So we do have to be creative to generate designs that are acceptable to encourage people to take part. And as you say, things like placebos are very challenging. Interesting, when we set up the interim trial, we thought that was going to be a really difficult trial to sell to people, because we're actually comparing the standard continuous to less drug. And we were thinking, how on earth is any patient going to accept having less rather than more? And so part of the trial involving the patients includes some patient experience and some questionnaires about what it's like to take part in that trial. Actually, so far, we've not had any patients decline that study, because they're seeing that actually this is a way of managing their toxicity better as well. And people are aware that these chronic side effects are debilitating in terms of their quality of life. So what we might think and what patients might think are different. So it is very much about teamwork. It is very challenging. Clinical trials are not for everybody. But I think if we bring ourselves together and work together as a team, then I think it's much more likely to work.
Thank you. In the interest of time, we have a question and answer session at the end with all of the panellists. So let's save some of the questions for then, unless we've got time. Thank you very much, Dr. Pippa Corrie.